This video provides an overview of Hantavirus, a rodent-borne viral disease, covering its introduction, transmission, symptoms, and prevention. Hantavirus is typically transmitted through zoonotic spillover. Humans inhale aerosolized virus from contaminated rodent matter. Human-to-human spread, while rare, occurred in the MV Hantavirus outbreak, facilitated by the ship's closed environment. The Flight KL-592 case study illustrates global dispersal and contact tracing. Risk categorization was based on proximity and contact with the symptomatic patient, classifying individuals into high, moderate, and lowest risk groups. Hantavirus diagnosis is challenging due to the clinical mimicry with diseases like COVID-19 and influenza, especially during the 72-hour blind spot. Detailed travel and occupational history are crucial for early diagnosis, alongside serology and RT-PCR testing. There is no antiviral cure for Hantavirus, making supportive care life-saving. Early use of ECMO for cardiopulmonary decompensation can yield an approximately 80% survival rate. Infection prevention protocols include standard precautions, isolation, and specific PPE. The Tenerife evacuation was a complex logistical operation involving 22 nations. Steps included onboard triage, zero-contact disembarkation, biosecure transit via isolation pods, and subsequent repatriation and quarantine of 122 individuals. Despite Hantavirus's high mortality rate, the global threat is considered, quote, extremely low. This is due to inefficient human-to-human transmission, the lack of endemic rodent vectors outside specific regions, and aggressive containment measures. A key challenge is the lack of globally licensed hantavirus vaccines. R&D efforts, such as those by Mabion and CEPI, focus on a recombinant protein vaccine targeting the GNGC spike complex to block the virus's ability to infect human cells. The One Health imperative highlights three nodes: ecological shifts causing zoonotic spillover, global mobility amplifying spread, and the need for pathogen family preparedness. This suggests building R&D roadmaps for entire families of viruses. Key directives include clinical vigilance, rapid containment, and strategic preparedness. Hantavirus pulmonary syndrome must be considered in differential diagnosis. Public health must support One Health surveillance and sustain funding for R&D countermeasures. Infection prevention and control measures escalate across three tiers. Tier 1 involves environmental control like decontamination. Tier 2 is standard patient care, requiring isolation rooms. Tier 3 includes high-risk interventions with strict airborne precautions, especially during aerosol-generating procedures. Hantavirus has an incubation period of 1 to 8 weeks. Phase 1, the early symptoms, includes fever and severe muscle aches. Phase 2, the cardiopulmonary phase, brings shortness of breath, pulmonary edema, and rapid progression to shock. For hantavirus, there is no specific treatment or vaccine, making supportive care critical. Early intensive care and cardiac monitoring are essential. Starting ECMO early during cardiopulmonary collapse can increase survival rates to approximately 80%. Hantavirus pulmonary syndrome progresses rapidly to severe respiratory failure. Early symptoms, from days 1 to 7, include fever and muscle aches. Late symptoms, from days 4 to 10, involve coughing, shortness of breath, and often require mechanical ventilation. The MV Hantavirus departed Ushuaia on April 1, 2026. Passengers traveled through endemic regions, exposing them to the virus. As of May 12, 2026, there were 11 confirmed cases and 3 deaths linked to the outbreak. New World hantaviruses are carried by specific rodent hosts in particular geographic regions. For example, Andes virus is found in South America, hosted by the long-tailed pygmy rice rat. Sin nombre virus is associated with the deer mouse in North America.